Before we step into episode 23, I want to introduce someone who'll be joining me more regularly on Too Light, Too Dark. Damien Black brings a way of thinking that isn't afraid of the shadow, someone who understands that growth doesn't come from bypassing complexity, but from engaging with it. Our conversations naturally move into that in-between space where insight meets uncertainty and the psyche gets honest. Damien, as we step into this shared space together, what's alive for you right now, mate?
What's alive for me? First of all, thanks very much for having me on the show. What's alive for me is the lack of nuance in public debate. And I think we can blame that on social media to a certain extent, but ultimately it's the people that make the place and it's the people that make space being social media or what have you. So with you moving forward, I'm hoping to bring some nuance back into the conversation because I think now more than ever is precisely what we need.
I agree. So, for you, our listener, and our supporters who've been so kind and generous for your time, that's the energy, that's the commitment that we're bringing into this next chapter at Too Light, Too Dark. This isn't about having the answers, it's about staying in dialogue with what's emerging consciously and unconsciously. With Damien here, this conversation is going to get wider, it's going to get deeper, and a little more honest. So, with that, we hope you enjoy episode 23. So, welcome back to Too Light, Too Dark, the space where shadow meets light, and we look to find the authentic and lived reality of difficult social complexity in the spirit of healing, recovery, and understanding. Our guest today is an esteemed voice currently based at Princeton University. His work focusing on overdose prevention, harm reduction, and ethnographic research, but his path into this field didn't start in academia. For research, he spent years working directly alongside people who use drugs, supporting them on the ground and learning from their everyday realities. So, with these words as flowers of introduction, welcome Dr. Benjamin D.Scher to the podcast.
Thank you for that lovely introduction, Leon, and yeah, great to meet you both.
And thank you so much for dedicating some time. We really appreciate that. So on to origins. So what was the moment or a series of moments, Ben, that first pulled you towards working with people who use drugs?
Yeah, so I was born in London, but I actually grew up in Vancouver, and I don't have the accent to show for it, but my school years were spent in Vancouver. And when I was about 14, 15, there was an amazing organization that came into our school. They're called the Ali Outreach Project. And their mission was to kind of raise awareness amongst students around kind of the drivers of homelessness and overdose that was so incredibly visible in Vancouver. For those listening and for you guys as well, if you don't know, Vancouver has one of the highest rates of overdose death for any city in North America, highest rates of homelessness for any city in Canada. And so, yeah, growing up, everyone is kind of very aware of this, but without really kind of understanding what was driving the situation. And so, during my school years, I worked with this charity, going around schools and doing workshops, but also going into the downtown east side, which is this area of the city that has the most visible kind of homeless community, and really learning about harm reduction and learning about kind of the ethos behind all these different interventions that were being implemented in the city. So from a fairly young age, I was exposed to kind of a different approach to drug policy than in many parts of the world. And that kind of acted as a catalyst for me, going to university and kind of staying engaged with these topics.
I'm imagining that taught you something that you don't learn in the textbooks. We'd just be interested to know how the two dovetailed in your experience, the lived experience versus the the more theoretical side of knowledge.
Yeah, definitely. So I'll just come back a little bit to what happened after my school year. So I actually moved back to the UK after school, and studied anthropology and philosophy in my in my undergraduate course, and that's kind of where I was first exposed to qualitative research and ethnography. But I always saw it as kind of an academic discipline that wasn't something I'd actually be able to do. Um, so after my undergraduate course, I moved back to Canada and did a master's in anthropology and public policy. And it was during that time that I started working in and doing research on supervised consumption sites. So I was working in Vancouver in these community spaces where people are allowed to bring their drugs off the street and consume in front of healthcare professionals, so that if they overdose, there's someone there to respond immediately. And there are a whole number of benefits that come through these services. First and foremost, they save lives. No one's ever died in one of these services, but also it brings visible public injecting off the street into a clinical setting. People also getting connected to broader health services once they come in and engage around their drug use. So I was seeing people who maybe hadn't engaged with a GP or a doctor for a year or 2 years, but upon coming into the consumption site, they were then able to meet with a doctor, to meet with a housing worker. But actually, what I was interested in during my master's was how police engage with these services, because at the time, police knew that everyone coming into a supervised consumption site is bringing illegal drugs into the service. And so what we were finding is that police were actually patrolling around the sites and were picking people up as they were kind of approaching, walking towards the site, or even as they were leaving. And so that was a really, really big problem. After my master's program finished, I then stayed in Vancouver and started working full time for an organization called the Lookout Health and Housing Society. And they run homeless shelters across Vancouver and British Columbia. They run outreach teams. They run supervised consumption sites. They've got kind of longer temporary accommodation that is really harm reduction housing. So there'll be accommodation spaces where all the residents are people who use drugs. And so in the building, in order to prevent overdose deaths, they have designated consumption spaces where residents can use drugs and are supervised by clinical staff. And all of these interventions were kind of implemented as a way to reduce the staggering number of deaths that were rising and still are. And all the research that's come out around these interventions has shown that they're incredibly effective, not just in reducing death, but also connecting people to all these other services that can improve people's health and well-being. And that includes drug treatment. So a number of studies have come out from Vancouver showing that when people engage with harm reduction services, their chance of actually going to detox and engaging with drug treatment workers, whether that's methadone, buprenorphine, or kind of more abstinence-based treatment programs, they all go up when people are actually able to engage with harm reduction workers. I did that for 2.5 years in Vancouver, working across all these different services. So I worked for St. Agency for a year and a half. The first year was in the outreach team in Hammersmith and Fulham. And then I moved into the Housing First team in Hammersmith and Fulham. And that was really kind of what made me interested in pursuing kind of academic studies and doing a PhD, is that I just come from Vancouver, where harm reduction is so embedded into kind of the homelessness sector. And then when I moved back to the UK and started working for St. Mungo's, I saw just how absent kind of knowledge around harm reduction and just as a practice it was in the outreach services that were being delivered. When we would find someone on the street in London, all of the questions we would ask were around patterns of drug use as a way of informing kind of an abstinence-based program, and there was very little talk, basically no talk about naloxone or overdose risk or reducing harmful behavior without really pushing abstinence. And a lot of the housing providers that we were supposed to be bringing people to, once we'd found them on the street, what didn't permit drug use. And so as a result, people either wouldn't be accepted into the accommodation, or they would have to lie, get a space in with this housing provider, and then sneak out into the back alley to use drugs, put themselves in these really heightened overdose risk situations because they weren't able to be kind of upfront with their housing provider. And that really was, it drove a lot of overdose risk situations. It really kind of blurred the relationship between case workers and case managers within these accommodations and the clients. And these were situations that I wasn't really seeing in Vancouver, where harm reduction was so embedded into homelessness practice. And that really kind of motivated me to want to do a PhD that was comparing these two different systems. As I was working I applied for a number of different PhD programs and got accepted in the Department of Social Policy and Intervention at Oxford. And yeah, that was kind of the beginning of my research, was wanting to do this comparative study between the UK and Canada. At the time, my supervisors at Oxford were just starting a study in Birmingham that was looking at the feasibility of implementing an overdose prevention center, a supervised consumption site. And so it just matched on really well, me being able to go back to the organization I worked with in Vancouver to start doing kind of ethnographic, participatory research with people who access these really robust harm reduction services in Vancouver, and then comparing that to the lived experience of people in Birmingham who have very, very little access to harm reduction services, who are using drugs in public spaces, and basically looking at how they navigate access to housing and access to care when the prevailing form of drug policy is just so hostile and is very police driven. And so, that was kind of how my PhD started, doing this comparison between Birmingham and Vancouver. And then actually halfway through my PhD, I was put in contact with people from Greece. So they just opened up a brand new overdose prevention center there. And they were interested in collaborating and making it kind of a three-way comparison. And so analytically, it worked really well, because you had Birmingham, where there's very little harm reduction services, Vancouver, where it's on kind of the other extreme, really kind of a global leader in trialing and pushing the dial on progressive forms of drug policy intervention. And then Athens, right in the middle, that had just started its journey of trying to provide kind of innovative forms of harm reduction care. And so, that was what my PhD looked at, these three different case studies, and then kind of a more comparative chapter towards the end. And then I just really loved the research, loved the teaching, really saw kind of a perfect balance in this career between keeping one foot kind of within frontline services and staying really engaged with people who use drugs, people who access services, working with people who access services, specifically with the aim of better designing and better conceptualizing drug services, harm reduction services, homelessness services, but then also being kind of in the academic space, where I could also engage with policymakers and speak with people who can actually kind of make a difference in how these services are designed. So, towards the end of my PhD, I started applying for academic positions in the UK, in Canada, in the US, and ended up just getting one offer out of maybe 20 or 25 applications I did. So, in August I started as a lecturer and postdoctoral research associate in the Center for Health and Wellbeing here at Princeton. And my research now is kind of pivoting a bit more towards the US and trying to look at, I mean, we can talk a little bit about this later on, but the US has seen a huge drop actually in overdose deaths in the last year. And that's kind of correlated with an expansion of harm reduction services. And so there hasn't really been much research done to kind of correlate these two. Like there's a lot of theory. And so I'm starting a new project now here in New Jersey, so the state where Princeton is located, to look at can we really prove that expanding harm reduction services has been a direct correlative factor, or whether this drop in deaths has simply been because kind of the purity of fentanyl within the drug supply has come down. A lot of kind of the early research is saying that it's because the drug supply has shifted and less to do with harm reduction services. But yeah, I'm interested in really exploring this question as to whether expanding harm reduction services can have a really positive impact on drug-related deaths.
You talked about a recent reduction in the number of deaths. It's been something like 500,000 deaths due to overdoses from opioids in the US in the last 20. I mean, the figures are pretty shocking, right?
The number of deaths in the US were between 120 and 140,000 a year, which is insane.
Many people know the US has a huge problem with gun violence. UN figures tend to put the number of firearms-related homicide deaths at around 10,000 plus a year, which is obviously a huge problem. Certain people on the Republican right might not think so, but most people think it's a problem. This dwarfs that, essentially. So when you talk about a recent reduction in fentanyl and opioid deaths, because of harm reduction or other causes, that's a huge question, right? For you, for everyone.
Yeah, it's a massive question. And so they went from having around 140,000 deaths a year to last year, that number dropped to 80,000, which is still by far the highest, both in numbers and per capita, for any country in the world. But it's still a drop of around 40%, which is huge. And it's just really important for us to try and understand what has driven that decrease, because that can give us some really interesting kind of insights into which areas of policy need to be pushed further because they are effective, and which areas of policy need to maybe be pulled back. And so, yeah, that's kind of my new area of focus now, is looking a bit more at the US. But kind of from a kind of framework and theory standpoint, I've always been interested in these larger structures, these larger policy structures, and how they impact not just people's lives on the ground, but also broader trends. And so often, drug research and addiction research is looked at through the lens of individual behavior, and kind of how people govern their own lives and how that impacts outcomes. But actually, from a research perspective, you can really kind of dial in on specific policies, like the overt funding of law enforcement and drug enforcement, and how that is a huge driver of risk and harm and overdose death, or other things like the lack of opioid substitution treatment coverage in a country, and how that also maps onto overdose death risk. So there are these really concrete areas of policy that we know kind of impact risk and harm and death. And so the way that I see my research is trying to shift the blame away from individuals, and to shift this onus of responsibility away from individual behavior, and really to try and focus on these larger structures and these larger policy frameworks that create these environments of harm and create these environments of risk. We know that drug use is ubiquitous across society, across levels of society, but also that drugs have been used throughout history. And so why is it that now we're seeing drug deaths at unprecedented levels compared to 70, 80 years ago, when drugs were also being used at very, very high levels? It's not that kind of us as individuals, as humans, have changed, but the environment in which we exist has changed. The drugs supply has changed. The drug toxicity has gone up. levels of poverty have gone up. Access to care has decreased. The funding available for drug treatment, for harm reduction, has all gone down in many parts of the world. And so what I'm interested in is, away from just blaming individuals, which is something that we do very, very well in society today, how can we actually design policy in a way that, reduces harm to individuals?
You've made some great points there, and I just want to kind of summarize some of that. And I hear, I suppose, your grounding and your initial steps in this field is in Vancouver, and it makes me think Gabor Mate, it makes me think Hastings, it makes me think of that sort of Lower East Side where, the chasing the hungry ghost, to quote Mate directly, is commonplace. And there's like a really rich grounding. And then I wonder what that felt like coming into the UK space as well. Because I've often found, and I've spoken to Canadian harm reduction practitioners, and we've had a sort of peer support worker right at the very start. We had an RMN on here who was a nurse who was responsible for one of these sites as well. And I almost felt like it was trying to compare apples and oranges in a certain way based on my own personal experience and professional experience. Can you just talk about that and what that actually feels like, Ben?
Yeah, it's a really great question. I mean, from a kind of high level perspective, when I moved back to the UK, I found that just the understanding of harm reduction and the ethos of harm reduction, and kind of the belief that people can make really positive changes to their lives without having to go abstinent straight away, but that might be something that comes in 3 months, in 5 months, in 6 months. It might not ever fully come, but that people can make huge beneficial changes to their life, wasn't really a part of kind of the British understanding of how to engage people who are living on the streets. And that actually, it pushed many people away from services when they started to understand that the only care they were able to receive is once they kind of agreed to be fully abstinent from drugs. And so, like what I was seeing in Vancouver is that by being able to come into spaces like supervised consumption sites, it was a way for people to get exposed to a whole range of auxiliary services that people in the UK who were living on the street, using drugs on the street, just did not have access to, or they had to jump through so many more hoops in order to get FaceTime with professionals in that same way. And so for me, the ethos was, was very, very different. On the flip side, though, although I come from a, I guess, a tradition of like very radical harm reduction, I also believe that drug treatment and harm reduction are very compatible and actually work best when they are kind of together and in sync. And so an issue in Vancouver is that actually drug treatment is very poorly funded, and that often when people come into harm reduction services, once they've built up trust with staff and they themselves feel ready to seek out detox or seek out drug treatment, they're still placed on month-long wait lists. And so I think that even though we know through research and also just through kind of firsthand experiences, is that that harm reduction spaces are really brilliant in facilitating that engagement, drug treatment is still massively underfunded and people still have to wait ages and ages and ages. And so I think there's still a ton of work to do from both sides.
I kind of struggled with that because my idea was to bring these practitioners from them spaces on and it helped me understand where we were stuck in a lot of ways in the UK. And I think me and Damien have probably been at the sharp end of this as well. And you mentioned the word hostile, and me and Damien have often felt like we're pressing up against a hostile system. And I wonder, in your current research and where you sit at Princeton, for example, how difficult is it to navigate that hostility, especially in the socio-political climate? And maybe before you respond, Ben, Damien, I wonder if you can pad out my thinking there.
What really jumped out at me from what Ben was saying about his experiences, where, this is still true today. If you walk into a GP and say, I'm having serious problems with depression or suicidal thoughts or anxiety, or, things are not well in my mind. And I know that to the point where I'm coming to you and asking for help. Maybe it's changed in the last couple of years, but up until recently, at the very least, they would say, well, have you been clean and sober for 6 months? And if not, then essentially, I don't want to swear, but essentially do one. Now, frankly, I might expect that from a hardcore religious community, and that's their prerogative, I guess. Certain people have their worldview. But to be told that by the state, and it's meant to be a secular state, in the UK, we are a secular country, the US too. And to be told that, you do not say that to people who are struggling. You try and help them and get them to the point where maybe they can start to think about weaning themselves off whatever it is they're taking that is exacerbating the problem. And yeah, I've been on the receiving end of that. And I'll caveat this, I'm sober. I don't drink, I don't use drugs, haven't done for a while. But I still, I won't lie, I'm personally quite incensed by that. That idea that it's okay for a government, as a matter of policy, essentially, to turn around and say that to people who are struggling. And the thing you were mentioning as well about, abstinence, a good result doesn't always look like total abstinence. I mean, from day one, we're told, that's it, you've walked in our door, therefore you've got an insoluble problem, very much like what you were saying you found here, but it's zero or hero. You either get totally clean and totally sober, you are a Puritan going forward, or you're in perdition. And it's the kind of stuff they tell you in AA. Okay, but you could say, well, AA, that's a private organization. That's their prerogative. They have a right to set their rules. But when governments start saying that, it makes me very, very uneasy. So the things you were saying about that, Ben, where you found something of that order going on is, and it feels hostile. If I was still active in addiction and I'm experiencing mental health problems, and let's face it, the two more often than not, feed into one another. Yeah, Leon, absolutely. That's going to feel like a hostile environment. Why am I going to go back there? I'm out the door. I'm not going to go back there again seeking help. I mean, it's a travesty. I find that shocking, and I'd be really interested to hear more about what you think can be done to arrest that, because I think the harm reduction approach is certainly, it seems like it's more on the right track. I'm not saying it's going to be perfect. You know that better than any of us. But that seems far better than the sort of, zero or hero, the Puritan versus sinner approach that governments are now taking in supposedly secular states. I find that really unsettling.
Yeah, I mean, my kind of view on this is that when someone is struggling with their drug use, they may be ready to access kind of drug treatment, whether that's 12 steps or going on to substitution therapy or whatever it might be, and those programs can be very effective for some people. But there's also there is also a proportion, fairly substantial proportion of people who are drug dependent, who aren't ready for treatment, or for whom treatment hasn't been successful multiple times. And so within that gap between they go back and try and seek treatment again, does that mean that because they're still using drugs, the state just completely kind of disregards them and gives up all responsibility? And that's what I saw through my PhD research in Birmingham, is that a lot of people who were kind of living out on the street, using drugs in public, said that they were kicked out of accommodation because they would relapse. And then they'd try and go into drug treatment, and there'd be these huge long wait lists. And so they were stuck in this cycle of not being able to access housing because of their drug use, but then not being able to access residential treatment because these huge NHS wait lists. And so people are kind of just in limbo. And that's really where harm reduction services can fill the gap, because it's saying we are here to support you and to provide you with care as much as we possibly can without enforcing abstinence on you. And for many people, it's not just life-saving in that it keeps people alive, but it's also kind of the support system that gives people a sense of dignity that gives people their sense of respect back and their sense of humanity back for long enough, for the point where they then themselves say, no, I'm ready to go to treatment and I'm ready to go into housing and to take these steps myself, and to really empower people. If abstinence is forced onto someone, the chances of them being successful through that are so much more slim than when it's come from themselves and they feel ready and they feel empowered and it's their own decision. And so harm reduction keeps people safe and keeps people alive until they're ready to take that step.
And it gives them some dignity back as well.
100%. I mean,
the two go together, right?
The dignity aspect is huge. I mean, the research that we did in Birmingham was, so first and foremost was trying to understand whether an overdose prevention center is needed in the community. And so kind of from a methods perspective, what we did is we hired local people who use drugs in public, so who are predominantly homeless, to show us all of the current consumption environments. So where are people currently using drugs, and how could we shift that by implementing a sanitary, safe, medicalized facility? And I mean, the places we were taken to were absolutely shocking. There was abandoned buildings that had people kind of crouched in corners with broken glass and needles everywhere and the ceiling falling in. The chance of them overdosing there and actually getting found by an ambulance service is close to zero. But also from a dignity perspective, like we've just spoken about, how are people supposed to even start to conceive kind of a better future when that's the environment they're living in? I mean, there were some really harrowing situations we kind of encountered and came into contact with of these. There was a bin chute of a council estate where people would drop their bins into this kind of like room that would then get collected. And when we got taken there, I mean, I've got photos from this environment as well, but we were basically led into the bin chute, and there were 3 young women who were all under the age of 25 who were crouched amongst all of this rubbish, bins there, everything. And we interviewed them and asked them why they chose to seek out this environment. And they said to us, if we are in public, the chance of us getting arrested, assaulted, sexually assaulted is so high. Local housing authorities don't want to engage with us because we're high-risk drug users and there's wait lists for us to actually get into housing that can support our needs. And so they basically described going into these really dangerous settings as fully rational decisions. And when they kind of laid it all out, it really made sense as to why they wanted to hide out there. And we then were able to present the case. Look, if you have a safe overdose prevention center, supervised consumption site, it would be engaging the highest risk drug users in the community who are really, really struggling and who have nowhere else to go. We also documented children's playgrounds. So there were these parks with kids playing on swings and playing football, and literally 2 or 3 meters away from these swings were bushes where at night homeless community members were sleeping, were injecting drugs, and in the morning these bushes were just completely covered with needles and broken glass, and kids were playing right next to it. And so from that perspective as well, having a supervised consumption site removes all of that public litter. People are able to discard of their equipment in a safe, sanitary environment, and it's better for members of the public as well who aren't exposed to that needle debris. We interviewed residents, so there were parents who kind of described walking their kids to school and seeing people injecting in bushes. So we interviewed them. We also interviewed the individuals who were injecting in the bushes, talking about these feelings of shame and embarrassment and the lack of dignity that they felt when they were injecting, and then they had to rush because they knew that someone was approaching. They then developed these really deep abscesses and infections. And all of these situations that we encountered in Birmingham were 100% preventable.
So there seems that this kind of puritanical approach is actually not benefiting the sort of members of the public that these so-called puritanical types would approve of, the ordinary people who have nothing to do with drugs.
And you'll know this, Ben, from your own experience over here in the UK. You know that there's outreach teams and outreach workers about to walk into that tonight in Tower Hamlets, in Hammersmith and Fulham. No matter what colour your lanyard or your agency or the organisation you represent, that is a reality for people working in the field and doing that right now. And as a follow-up, this speaks to participation. This speaks to, I suppose, something I read and build up to our conversation, Ben, around ethnographic methods. And for you, why is that approach essential for understanding drug use? Because I think I know, and I'm sure Damien's got his own insight, but yeah, where do traditional models fall down in the face of what we know and understand, Ben?
Yeah, so ethnography as a research method comes from the discipline of anthropology. And basically what it entails is just, as a researcher, spending as much time as possible with the people with whom you're conducting research with. And so kind of at a basic level, that's what ethnography is you spend a significant amount of time with people. You can then do interviews and focus groups, but the crux of it is just being with people and taking notes and better trying to understand their life. The second part to kind of the method that I used in my PhD research is something called participatory research. And so I tried to kind of marry these two approaches together. And what participatory research is actually allowing and working with community members to lead on all aspects of the research. So in Birmingham, what we did is we convened a group of community members who use drugs in public, and they basically came up with the research questions. We then presented them all these different ways of answering the question that they came up with, and they chose the methodology. We then trained them up in how to do data analysis, all the way through to actually disseminating the research, where we had some interest from a few MPs in the House of Commons who actually hosted an event on overdose prevention centres, and the participants from Birmingham made a video where they spoke into the camera about their experiences of using drugs in public and how the lack of dignity they have, how difficult it is for them to access treatment and to access care. And so participatory research is basically kind of switching it from kind of researcher-led projects to community-led projects. And so what we find in doing that sort of work is that actually the questions that you ask are way more applicable and kind of resonate more with the needs of the community. But then also the kind of the actual data that you get is way more context specific and relevant. And so just, speaking back to the Birmingham experience where we had community members lead us out into the community and document these environments and lead in these interviews. So we'd interview people who are using drugs in bushes down by the canal bank, in these abandoned buildings. We also found a few different buildings that had been cocooned or were in the process of being cocooned, specifically because community members had nowhere safe to use drugs. And so they would go into these spaces. Cocooning is a huge issue for selling drugs, but it's also a huge issue because people then use drugs in those spaces. And a primary reason people use drugs in those spaces is because they have nowhere else to go. And so when you have kind of supervised consumption sites open, it reduces the need to co-opt these sorts of spaces. And so really kind of just coming back to the ethnography point, what I love about this approach to research is you're able to answer questions that traditional kind of quantitative stats research can't actually answer. You're looking at not just kind of documenting from a numbers standpoint what the outcomes are, but you're able to actually capture the drivers of those outcomes and really understand how people navigate the world around them, and what is actually producing harm, what is actually putting people at risk. I can say that so for the Birmingham research, how it actually started was was with a quantitative component. So we started off by gathering baseline metrics related to all of the things that an overdose prevention center supervised consumption site could impact upon. So we looked at the number of people who overdose each year in this community, the amount of drug treatment coverage in this community, the amount of drug-related litter in the community, the number of arrests because of drug-related issues. So gathered all these baselines so that if a site was opened, we could then track over time and see the impact that the site was having. The second part was the ethnographic qualitative component, where we did these ethnographic sessions and documented the current environments and did focus groups and interviews. And then when we were invited to the House of Commons to present this research, we presented both elements, the hardcore stats and the numbers demonstrating kind of the quantitative need, but then also we showed these stories, these real human stories of suffering, of shame, of harm. And that is actually what you could tell, that's what gripped the policymakers in the room the most. The numbers were abstract. When you say that there's this many thousands of people who contract infections and abscesses preventable in Birmingham.
They'll hear that
versus-
all the time, MPs anyway. They'll hear that all the time.
They hear that all the
won't they?
time. But actually, when you can show a video of a young woman who is living out on the street, who's being victimized constantly, who's drug dependent, who isn't receiving the care that she needs, who has all of these abscesses and wounds that aren't being treated, and who doesn't want to engage with healthcare providers because they push abstinence on her every single time she wants to go and speak to them about an infection that's actually in a way unrelated to her drug use. What she needs is a harm reduction space where people can address all these other issues and then see the drug use as something that comes kind of in a conversation further down the line. When you present those really harrowing stories to policymakers and MPs, that's what actually grips them in. And so from kind of my position as a researcher, I'm moving now into kind of mixed methods and trying to get better at kind of the quant stuff, but I will always stay true to my kind of anthropological, ethnographic kind of background, because I see kind of the impact that it has on policymakers when they hear those stories. And it's the human side to the war on drugs. It's the human side to the drug policy space that so often gets ignored. And so that's kind of where my passion for research really lies.
And is it moving? Is it moving the dial? Just one question I had just to follow. I mean, you say you've been before politicians, you've seen it have an effect on them. I mean, what's the follow up been like, or is that still very much a work in progress? Because there's going to have to be some legislation to get this changed, I assume, or is it, guys? You tell me, is it more left to local councils to decide this kind of thing?
Yeah, so I can speak. So just for the UK context, the history of the legislation really comes from something called the Crack House Statute, which it goes back to kind of the 80s, but there's legislation that states that you can't operate a facility in which there is an illegal drug use within the facility. And so all it would require is a small edit to say, unless it's for medicalized purposes. And so, yeah, there's academics that can speak much more to this, who are much more kind of their expertise lies in this. Like Professor Alex Stevens is really kind of clued up on the legislation. But Scotland opened the UK's first supervised consumption site in April of last year in Glasgow, and that was through an exemption from the Scottish Lord Advocate, who said we're not going to prosecute, even though Westminster still controls kind of from a more legislative standpoint. But the trick about the really tough thing about harm reduction is that despite the huge amount of evidence that exists around the effectiveness of all these different interventions, like needle and syringe exchange, naloxone distribution programs, supervised consumption sites, there's a huge evidence base. But actually, from the communication standpoint, all it takes is for the Daily Mail to come out with a headline saying government paying for addicts to shoot up all day. And that's what they do. That's what they do. When the Glasgow site opened, the headlines were horrific. They were stigmatizing and demonizing and completely ignored the decades of evidence we have around the effectiveness of these services. And so I think for politicians, it's really difficult. Like, even if they want to try and push more of a pragmatic, progressive agenda when it comes to drug policy, the risk for them is just so high, because actually a lot of these interventions, to understand them, it requires a bit of a conversation. It requires you to look at the research, to actually understand what the intervention is doing beyond the snippet of government paying for people to do drugs all day, which it isn't doing. It's all the evidence shows that actually people who engage, the really high risk drug users who are most at risk of overdosing, when they engage with harm reduction services, their chances of dying significantly reduce, and their chance of actually engaging with housing, drug treatment, legal aid, primary care, all of these other services shoots up. And so it's difficult. And I think actually the research community needs to do a better job of communicating the research in a better way, because it's just so easy to just shut down. And yeah, I mean, I'd like to think we're moving in a better direction. And there's some parts of the world where we are, but then there's also parts of the world like Canada, where traditionally has been kind of a leader in this. We're seeing now a record number of consumption sites being shut down in the more conservative parts of the country. In the US, we've seen Trump in his last budget pull federal funding for SAMHSA, which is the kind of the federal body that runs drug services and runs harm reduction services. There's a real attack on harm reduction services in the US. And yeah, even if you look at the cuts to USAID and the cuts to development, a lot of that money was going towards needle and syringe programs to prevent HIV in global South countries. And so there is just an attack on harm reduction globally, even though there are kind of pockets of progress. And so, yeah, I've been rambling on a little bit, but that's kind of my view on where it's going.
And in such a high impact line of work and the high impact research work as well, Ben, just for our listeners and maybe for myself who maybe has to navigate that space occasionally, how do you look after yourself, Ben? Because you've seen some things, I've seen some things, Damien's seen some things, and I think that's really important because a lot of our podcast listeners sit in that health and social care practitioner space, Ben. Like, how do you look after yourself when you see such a socio-political climate that's hostile, when you see the ability to have civil discourse about really complex subjects, really privy to a 4-year election window, when really a lot of the answers are staring you right in the face, Ben? So yeah, maybe you can speak to that. How do you keep motivated?
Yeah, no, that's a great question. And I guess I'll kind of treat that question in two parts. So the first is how I kept motivated when doing more frontline work. And then the second bit to do with how I kind of see that now through research. And yeah, maybe you two can speak to this as well. But when I was working in overdose prevention centers in Vancouver, this was at the height of the overdose crisis. Kind of 4 or 5 years ago, we were intervening in anywhere from 3 to 5 overdoses a day. But all of those were within kind of controlled clinical settings where every single time we were saving the person's life. And so seeing kind of how effective the service was, and also seeing the number of people that would come and engage around their drug use, and then 3 or 4 or 5 months down the line, once they'd built up that trust, moved on to getting their own place and getting accommodation and started seeing their doctor more. And seeing those positive outcomes is really what kept me going, despite being in such a tense and such a difficult environment where overdose rates were so high. I also had really brilliant mentors within those services, and I had managers who were incredibly supportive. I actually found it a bit, when I moved back to the UK, even though rates of overdose were much lower compared to Vancouver, I found that I was approaching that point of burnout more because working in the outreach team, we'd find someone on the street, we'd start working with them, we'd take them to a service. And then because the service was just so, um, was just not designed for people who are still using drugs. Either they would refuse them, or after a few weeks, the person would leave. That's where I really started to get demoralized and started to feel the burnout when I wasn't seeing the positive outcomes come through the outreach work, is that there was only so much we could do. We would find someone, we'd start working with them, and as soon as we'd move them onto other services, that's where the relationship between service and client broke down. And for me, that was the most difficult thing. And I don't know if that's something that Damien and Leon, you can speak to maybe a bit from your work as well. But yeah, when I started to really come into contact with how poorly designed the homelessness system was in the UK in terms of achieving those positive outcomes, irrespective of the individual's drug use, that's where I really started to burn out. From a research perspective, I get, so every time I have a positive interaction with a policymaker, or even have these sorts of conversations where it's with people who are receptive to hearing the evidence, that always gives me like a bit of a regeneration in terms of my motivation and kind of spurs me on. But I mean, yeah, it's really difficult. You can, like, for example, in the US, there's progress that's made, and then you hear that there's been huge cuts in federal funding. And so, I mean, just a flip side as well, since I've been here, despite this environment and context of huge reductions in funding, being able to work and engage with grassroots organizations here in New Jersey, which are doing such incredible work, despite this environment of hostility from a funding perspective, there's just so much resilience here on the ground. And I mean, it's the same in Canada. It's the same in the UK. Like what the grassroots organizations do, the smaller organizations who aren't competing for contracts in the same way, who are really driven by community members. When you see kind of the amazing work that's being done on the ground, that also kind of spurs me on, remotivates me. And increasingly, I'm trying to partner with those sorts of organizations for my own research. So, yeah, I guess those are the two. Yeah, from frontline work and research, that's just kind of how I stay positive, I guess.
Sounds like the two have dovetailed quite nicely in your chosen line of work. I mean, they continue to inform each other. Okay.
Yeah, definitely.
Yeah, I have to say I'm still shocked by when they run headlines like that saying, "Oh, these centers are just paying for people to shoot up." But isn't it weird? Because I know I said this earlier, but ordinary people are going to benefit from this, right? Because it means you won't have a needle park adjacent to your kid's playground. It means there will be a safe space. And I just wonder how people fall for that. When they've seen the positive outcome of having these centers, and then they get shut down, and then what are the ordinary non-addicted members of the public want to see? They want to see the problem back on their street, in their backyard. I mean, that's the part. I understand there'll always be the arguments about the money. Where's the money coming from? Always the money. But the social aspect, I would have thought, surely non-drug users that don't have any relatives that have drug problems, surely that it would be clearly in their benefit to have these centers, if nothing else, so they don't have to see it. They don't have to watch out for their kids when they go to play on the swings or whatever. I mean, that's the part that really, I'm probably just being naive, but that's the part that really loses me.
Yeah,
How they
I mean,
do not see the benefit.
there's something else I just want to touch on, is that like I'm very optimistic about the role of harm reduction services, and because from an evidence perspective, that's what all the evidence points towards. But at the same time, I don't want to position these interventions as magic bullets that if you just set up a consumption site, that will fix all the problems in society. What we know from the research with supervised consumption sites specifically is that they're very effective in improving outcomes within like a 1 kilometer radius of where the site is set up, because people aren't going to commute from very long distances to get to these sites. And so they're very, very effective in specific contexts. And then if you look at some of the other interventions like naloxone distribution programs that are also very effective in reducing overdose rates, needle and syringe programs, they're also very effective in reducing the transmission of disease and the transmission of infection. But ultimately, what's going to make societies healthier and safer and less people dependent on drugs is these much kind of higher level structural changes. We can map all of the statistics of drug related harm and drug related mortality to areas of deprivation in the UK. So parts of the UK that are poorer, that have less, that have higher rates of comorbidities for a number of other health related issues, also map onto the areas where we're seeing the highest rates of drug related death, drug related harm. So it's not just a question of if we just roll out harm reduction services everywhere, things are going to get better. It's also just improving societies more broadly and having people having stronger communities, having better access to healthcare, better access to education. And so ultimately, harm reduction services are very much needed, especially now where rates of death are so high, but they will always be kind of band-aid interventions to these much bigger questions around why do we have such high rates of homelessness in the UK? Why do we have such high rates of people coming out of care, whether that's childcare, child services or prison or hospital, who end up on the street and who end up drug dependent? Like they're these much, much bigger questions that I think that as a society we need to answer. And there's a space for harm reduction interventions to come in and to reduce mortality and to reduce drug related harm. But until we answer these bigger questions, we're not gonna solve everything.
I would chip in that the sort of one-liners from certain parts of the media engaged in lazy storytelling when it comes to these multi-layered complex issues that need serious discussion with serious people, but with a real underpinning compassion. In terms of little green shoots, Ben, over here in the UK, I can offer, I've seen naloxone more available. I've ran services myself where, for example, if I'm welfare checking somebody who's living in a supported housing unit, who's experiencing homelessness, I've armed my staff with naloxone before even walking into their living space. And that is becoming very gently more common practice within spaces that I've been. I would also add that we've had, and I'm going to give a shout out to Ed Addison, who has the People's Recovery Project. You might know Ed from earlier in your career, a little grassroots organization where he started to understand the system and then apply that learning into a more grassroots model, having lived experience in the DNA. It's thinking. I'll add as well, Jessica Turtle from the Museum of Homelessness, very similar, who sits in that kind of artist, activist, and now a support base. I've worked with the Pavement magazine again, so we're pushing the sort of low threshold harm reduction model. And you mentioned D.Scher, who we've been in early introductory conversations with, actually come on the podcast. And already that's been an hour, which has flown by. I'm sure Damien and myself and you could chop this up for another 5 hours on multiple levels. And just to give you a dessert question directly, if there was one thing to change, if you could change one dominant narrative about drug use in public discourse, Ben, what would that be? And why does that shift matter right now?
Yeah, so that's a really great question. I think that you touched on it there, in that as a society, especially now, we're looking for these really easy answers to actually very, very complex policy issues. And when it comes to drugs, often that easy answer is to blame the individual and to say that this is because of someone's choices in life. This is because of things. I mean, a couple of years ago, I remember Suella Braverman coming out and saying that homelessness is a choice, and that people sleeping out in Westminster, they're there because they actually want to be homeless and they prefer They prefer that lifestyle, she called it. For anyone who's worked on the ground in outreach or homelessness services, know that that's the furthest thing from the truth. And so I think that if I was to say the biggest shift, what I would like to see is for us to actually slow down when we look at these complex policy problems, and to switch the focus towards the structures and the policy frameworks that actually dictate what the situation looks like on the ground. And just coming from a drug services, from a homelessness services standpoint, and even from a research standpoint, when you do research around drug services, or you're looking to design drug services, if you do that without the input of people who use drugs or people who are clients of those services, you're going to have huge blind spots. And so too often I'll see kind of reports by drug services that are doing reviews of the stuff that they're doing, but they just won't speak to their clients, or they won't even speak to potential clients. And I think that's a huge blind spot. And so just from my perspective, from a research standpoint, I think we have to include people who use drugs more in research, but also in the design of services. And ultimately that leads to better outcomes. And so, just switching the lens from individual blame to a real structural focus. And then from a research standpoint, just including people with lived experience and living experience more, because it is genuinely proven to increase the quality of the data, and then ultimately the quality of the services that we can then design.
I suppose the other one would be, if you could say, is there for students or early career researchers that might be thinking of going down the same path as you did, Ben, is there any particular mindset or skill that matters more than academic credentials, or just as much? If you had to just, bit of a label question, but if you had to throw one quality out there that you would say that's the thing you should cultivate going into this life, because it is a life for you, really, I think, what would it be?
Yeah, that's a really great question. I think that whether it's doing research around homelessness or research around drug use, or any other health related topic, I think that actually learning how to listen to people, and learning how to actually sit and listen and take it all in before trying to do some deep analysis and trying to unpick what's going on, but really spending time with the community members that you're doing research with, is the best way to go about it, because you'll have a much kind of more contextualized, better understanding of the deep rooted issues at hand. And it also kind of brings the human side back into research. Like I think a lot of the time, academia can be quite kind of ivory tower. People kind of working as armchair academics, like theorizing about the world that's out there, when in actual fact, kind of the best evidence that I've seen around kind of the drivers of drug related harm have come from researchers who have been able to really embed themselves within the population that they're working with, and to keep kind of this duality of closeness, but then also analytical distance at the same time. You don't have to be like an ethnographer through and through, like that's all you do. But even if it's just building a relationship with the drug services in your community, even if you're a quantitative researcher, getting a better understanding of the topic that you're kind of doing this big data modeling on, you'll be a much better researcher if you learn to kind of sit with the population that you're working with, and kind of bring the humanity back into the research process. And so that's been something that's really helped me kind of not just give me kind of better understanding of these issues, but also kind of keep my passion for these topics, despite kind of reaching that point of burnout at a few different stages in the last few years. And so for any young researcher, or even for anyone who works within drug services who's interested in research, or interested in maybe switching into the research path, keeping your foot in the door with drug services and with people who use drugs, and keeping that closeness is is it's so important. It's so important. So yeah, that would be my one snippet, I guess.
So that brings us to the end of our time, and I think we landed the point excellently there that one of the things that stands out in this episode is how much of this work comes down to listening, like really listening, engaging your ears. I've seen it time after time in a recruitment setting. People say, I'm a great listener, I'm a great communicator. Are you? Are you really? And so to people whose experiences are usually filtered through data, headlines, or even moral judgment, that listening piece is going to be key moving forward. Throughout the episode, Ben, you've pushed back on the idea that overdose is about personal failure or that success in harm reduction can be reduced to abstinence alone. Instead, you've asked us to pay attention to context, the housing, the policy, the stigma, the criminalization, and the everyday conditions that make survival harder than it really needs to be. We've talked about tension between support and research, about staying human in environments where burnout is common, and about what becomes possible when people who use drugs are treated as experts in their own lives, not problems to be managed. So, if you take one thing from this conversation, let it be this: the stories we tell each other about drug use and ourselves shape the responses we think are acceptable. Changing outcomes require changing those stories first. So, if this episode resonated, share it, please sit with it, and keep this conversation gold. And with that, Ben, thank you so much for your time today. We want you to stay gold. We want you to stay balanced, and we want to stay beautiful today. So namaste to each one of you. Have a good one. Thank you so much, guys.
Thanks so much, guys.
Thanks, Ben.